in our programming. We know that we did suffer quite a number of setbacks last year, but we're hoping this year we will focus on our strength and move on and address some of the issues in our program. This afternoon, we will have a session being led by Dr. Seville, program advisor in Ministry of Health, and just ask him to introduce himself and with the network. Dr. Seville.
Thank you, Dr. Gambo. Good afternoon, network. Always a pleasure to be here and start the year again. From my side, happy New Year. All of you, wishing all of you and your families great blessings. Looking forward to the rest of it.
Thank you so much, Dr. Seville. I do recognize quite a number of people have joined us from different places, nursing schools joining us, and all colleagues from across the provinces and facilities. Thank you for joining us. So on the call, we do have Assistant Director, this communication, Dr. Henry P. Piri. We want to just invite Dr. Henry P. just to say hello to everybody on the call before we start our session this afternoon. Dr. Piri, are you able to unmute yourself and just pass your greetings to the network?
Yes, thank you very much, Dr. Kozia and Dr. Seville. At least are the two that I can see on this call. But everyone who's on the call, welcome to 2026. Let me start by saying a happy new year. Not so very happy for us in the department because we've got two bereavements right now. We're burying one today, we'll be burying another one tomorrow. But overall, I think I can see everyone who's participating here. I take it that you are healthy and you'll be able to carry out the mandate that will be stipulated in the coming few slides that the team will be putting across. And of course, even as we shall reflect on our performance during the year 2025, it should be able to guide us in terms of how we can change the architecture of doing things in the year 2026. So I'll not say much now. I'll talk later after we've listened to this presentation and we've digested it and we've all reflected on it. Thank you very much, colleagues. We may proceed with the presentation.
Thank you so much, Dr. Piri. So this afternoon, we will have a presentation. Dr. Seville will run through. Then after the presentation, we will invite questions from the network, clarifications, and then we'll also then hear from some of the program leads just to emphasize on some of the key issues that we'll be looking at this year. So without further ado, please allow me to invite Dr. Seville to come through and make the presentation. Then I think we'll also be joined by Professor Mlenga very soon, and he will also make some comments as he comes through. Thank you so much.
Thank you, Dr. Ziambo. I think we can proceed with the presentation. That's my name and my title at the Ministry of Health. Next slide. So as you know, with regards to the NSP, which should be coming to an end this year, this has been our goal as an HIV program, the ministry, and it's a similar goal that you find in our NASIF to reduce the incidence from 28,000 to 15,000 in 2026. And we'll see where we are. So this is the outline. We are going to look at the program performance. We'll look at the key challenges and successes. We'll look at program area priorities. I think those are the program areas, and we hope that some of the program leads are available to add a comment or two. We'll look at some of the programming innovations that we want to put in place, which can lead us to sustainability in view of what we went through last year. And we'll look at the program activities, upcoming activities of note. So this is from our ZDHS 2024. We can see that the prevalence of HIV is now at 8.7%. We can see that Lusaka is at 12, followed by Copperbelt at 11, Western at 10, then we have Central Province at 10.3 as well. Over the north, we can see Mchinga has the lowest in terms of prevalence of HIV. Next slide. This is just to show the slide, the graph on your left, to show the trends, that we can see that the trends from 2001, when on average, the total, we were at 15%. Now we are down to 8.7. This is, if you can compare males and females, we can see that for males, we are at 5.9, and for females, we are at 11.5. So over the last 20 plus years, you can see there's that gradual reduction in terms of incidence. This is also noted in the last 4 to 5 years. That's from 2018 to 2024. You can see that there was actually a market reduction from 11.1 to 8.7 in terms of incidence. Just to note that this is really because of the reduction in incidence, but also the improvement in population. Prevalence by sex, you can see, I think I've already alluded to the differences between male and female, but you can see that there's still a disparity between different geographical regions. Yeah, more obviously in the urban areas than in rural areas. You would see that even from the overall provincial. You can see that the provinces that are chiefly urban, the prevalence tends to be higher. For children, we are happy to have this result that now we know that prevalence for children is 1.2%. And this is not really reducing because, as you know, our PMTCT, the last 5 years, these are very low numbers. Previously, it used to be 1.1 when it was done somewhere in 2016. Yeah, so we haven't seen that much reduction. So here's one of the places where we need a lot of work. Again, more in the urban areas. With regards to incidence, as you know, we get this from the spectrum. This is our projection. We are still at 29,000. This is just because of the inputs that have gone in. We thought we had reduced to about 23,000, but when we look at the numbers, we are close to that 30,000. So we still have a lot of work. Remember, our target is to reduce to 15,000. Next slide. And this is just new infections by age. You can see that our adolescents and young people, that's 15 to 24, they have that disproportionate number. You can see which translates to about 35 to 40% each year, and it's not really reducing. Yeah. So this year, because of those changes that we saw last year, reduction in some of the activities, especially prevention activities, we think there will be a slightly of a bump of the incidence going slightly up. You can see those numbers. Next slide. With regards to pill HIV, those living with HIV, we are the number we used to be around 1.3 million 40,000. The revised spectrum 2025 shows that we went up by about 50,000 to about 1.390, just 6,000 people below 1.4. And this will increase slowly over time, right? And again, PHIV by age, you can see that would see a gradual reduction in the children who are around 55,000 now, adolescents and young people are at what, 109,000, and the rest are actually adult above 25 years old. Next slide. With regards to individuals on ART, here we just wanted to show the trend in the last 5 to 6 years, and we'll show the data for 2025. But you can see that we had that nice rise over the last 6 years, all the way from about 1 million to about 1.3 million and 12,000 people at the closure of 2024. We know that 2025 was a difficult year. It was a difficult year not only for programming, but also for data systems. So one of the things I would upfrontly say is that this year we need to work on our data systems. We need to work on our retention so that we are sure of what is the number. But this is where we were. And this is for children. You can see that, again, we were reducing because of that transition, and around the 2024, we were somewhere around 37,000 if you add those numbers depending on the age group. Next slide. Yeah, and this is for adolescents and young people, again, around 90,000 on treatment. And adults, that's the number when you compare different groups. Yeah, so really, current on treatment by age, when you, like I've said, when you use the combination for children, you can see it's 37,000. That's the closing number for December 2024. And we are going to discuss, like I've said, 2025 performance. And so if you use those numbers against the new spectrum estimates, you would see that out of the estimated 55,000, 37,000 treatment for children, you can see that our treatment coverage is at 67%, 85% for adolescents and young people, and we are at 96% for those above 25 years old. And that tells you where our efforts should be for treatment coverage. We should look at the children, we should look at the adolescents as well. Next slide. So if we use the previous spectrum estimates, you can see that for adults we are way around 99% and 95%. But the current numbers are the ones I've shown previously. Next slide. Yeah, so how's been our performance for this year? And this is data from the HMIS as of 16th January 2026. So you can see that in terms of HIV testing and yield, we reduced last year in the number of HIV tests. In 2024, we had 5.9 million tests compared to 4.8 million, pretty much 4.9 million tests. So the number of the testing themselves, they dropped by about 1 million less tests. And this is for us in facilities to answer what really happened. How come we tested fewer? We carried out fewer tests than the preceding years by 1 million. If you think about it, 1 million over 5 million, that's like 20% less testing that we performed. So this is areas where, like Dr. Ziambo was saying, we need to recover. With regards to yield, even the yields they did not improve that much. If anything, went slightly down. It was from 2%, 1.9%, showing that even the testing was not as targeted, as effective as it should be. Absolute numbers, we reduced again. That's case finding, those you are finding from 119,000 to 93,000. Again, this is a drop by almost close to 30,000 tests. So above 25,000 tests, positives, test findings. So you can see the underperformance. Obviously, people say the epidemiology is changing, but still, if you look at the performance over the last few years, the number has been around that 120,000. So it wasn't a good year, 2025, and we have to look forward to a better year this year in terms of HIV testing. This is the same numbers by month. You can see that there were actually some months that we did very badly. Even when you compare with the previous year, February is a month of note. This is, as you know, it was after the stop work order announcement, February, March, April. Over there, you can see the testing was very, very low. And we tried to recover around June. As we went towards the end of the year, again, September, October, we went down. And we know, again, what happened there. It's because of those restructuring, and so people are laid off, the changes, and so on with the funding landscape. And so we can see that it was a challenging year. Almost month by month, we underperformed compared to the previous year in terms of just carrying out the test. Same information or findings if you look at province by province when you compare year by year, and we can see that there were provinces which had some steep dip. Central province from close to 900,000 tests, that's 877,000 tests, to 580,000 tests, that's about 300,000 tests less. Copperbelt, similarly, almost over 200,000 testing less. And you can see that there were some provinces like Jinga, which were not so bad. Southern province, Lusaka, will commend you. There was a drop, but a modest drop. Eastern province, again, here you see that the core provinces, I would rightly say that, Eastern, Lusaka, Southern, Western, they didn't seem to have those challenges. But again, you have also provinces like Mchinga, Luapula, those who maintained as well, and Northern province, and Western, Northwestern as well. But two provinces, Central and Copper Belt, this is the data. And we know what happened with the implementation project there. They are the ones whose contract was outrightly cancelled. So this is just to show that all those things which were happening, they are translating themselves into numbers. Next slide. So this is positives. You can see that over 90,300 people that we found month by month. Again, we underperformed. Steep dips in February. The previous year, February, we expect the numbers, like we always said, to be around 10, 11,000 new cases, but we dipped to 7,000. And this was probably the figure that we were finding, 7,000 new cases every year, every month, month by month. There was a slight improvement you can see in June, but again, we went down in terms of new cases. Next slide. So this just talks about positives, again, by province, and we see which provinces had steep dips. You can see Lusaka, there's quite a market reduction of close to 5,000, over 5,000 reduction in new cases. Next slide. And by month, you can see in terms of positivity, again, here, interestingly, the month of February, we seem to have performed slightly better in terms of positivity, but we know that what really matters is not absolute numbers that we found fewer. Yeah, but we can see that by and large, we underperformed year by year in terms of even positivity, except in months like September and October, where we kind of had a better, and June, where we had a better positivity. And this is largely below the performance level that we want it to be. And this is by province. Again, you can see that we do have some provinces which still have very good positivity rate, Lusaka, but Copper Belt doing fine as well. But we do have Mchinga, where we need to really, really improve, and Eastern Province. Next slide. So who are we finding? Who are we testing? We can see that most of the time we are testing those 15 to 24. That's where most of the tests are going, which is a good thing. Yeah. But from the program side, we need to improve that number of those above the age of 50, and we'll explain why as we move on. Next slide. And similarly, new positives by age bands, there's need to improve for new positive for those on the later age. Most of the ones we are finding are within the age of 25 to 34, which should be the target population. Yeah, next slide. Yeah, and yield, again, the best yield is within 25 to 34 and 35 to 49, where we are doing very well. And here, the elephant in the room, Dr. Jambo is with me, is the children. You can see that our positivity rate for children has not been good. Yeah. And obviously, it's explained we got rid of, the screening tests and all other things. Yeah, but we still need to do a lot of work there. Next slide. In terms of ART stat, you can see that by and large, there was a reduction year by year, month by month, and steep reductions in certain months, especially February. June, seemingly, all the indicators suggest that it was a good month, but after that, we started going down again. Yeah, and this, when you compare with the previous year, 2024, similarly, we underperformed. Yeah. Next slide. And in terms of who we start on treatment by age, we can see it's the same age group that we are finding. Next slide. Now, concerning current on treatment, here there was a progressive loss. Even when we were finding a few people here and there, 7,000 a month and so on, 90,000. But absolutely, the absolute number we reduced. Starting the month about 1.3 million, closing it at 1 million in December. Obviously, you can say maybe data issues because December is not the report hasn't been complete. This is just January. Even if we pick November, which is 1.26, there was a drop of close to 50,000 people on treatment compared to this. So here we will not say what we think as program. It's you from facilities, because this section, this meeting, we speak to people from facilities. The question is, what happened in your facilities where you are working? Program leads, implementing partner leads, what really happened? How come we underperformed? You can't give, if you look at the curve, how we've been performing the last 5 years, we showed you the data. There've been some minimal or modest increase year by year, but last year we dropped. Yeah, so we really underperformed. Now, next slide. If we compare with the previous year, bad performance in terms of current on treatment per month. Next slide. Yeah, and just to show who is on treatment, we can see that it's the expected age group around 35 to 49. Now, we tried to see province by province, how's the performance. When you look at the targets or the expected, we can see that there are provinces that are not doing too well. And this is using the previous estimates. You can see that. So what is Western province is supposed to be Lusaka. What is Northwestern, there's some error with the labeling. And Northwestern is supposed to be the Copper Belt. You can see that Copper Belt has got that 78%. Again, more or less the least performing, and the 103 is for Northwestern. You can see that, which Northern Province, Western Province, sorry, which performed very well. Yeah. So we know where we are underperforming as provinces. Case in point is the Copper Belt province. Next slide. So there are some probably causes of the loss of current on treatment. We think there was an increase. There was an increase in interruption in treatment, the ITT, due to funding-related program disruptions. What happened last year, meaning reduced tracking and tracing activities. These are things that we need to start doing again. Reduced DSD service provision, cards, community RT distribution, health posts, and so on. We know that some health posts closed. Yeah, so those things really affected and really caused some increase in treatment interruption. Reduced community services as well. But there's also just reduced case finding. You can see from the data that as opposed to 11,000 new cases per month, we went down to 7,000. So, and this is probably reduction in the use of DSD models for testing. We did less testing for some key populations or priority populations. I know the data could not bring that, but we know from program that we had KP spaces closing and so on and so forth. There was some data management challenges. Yeah, reconciliation of the silent transfer was reduced because there were no people, to just reclassify where these individuals are and so on. But also we had recipients of care who are lost due to the migration to the Smart Care Pro, where we really need to do a lot of work this year. Next slide. So the major challenges faced in 2025 is not a secret. It's what we all know and experience is that disruption in programming and HIV service provision due to the stop work order and everything that followed, reprogramming and so on. And we did have some achievements. Mainly, we managed to continue the services, even though some indicators show that there was some underperformance. And with that, we are happy to say that things like commodity security, that was maintained, no one went without ARVs, and pretty much there was continuity of HIV services. We introduced LEN last year. We are proud of that. We came up with a minimum package of care. Smart Care Pro was rolled out, which we think it's a good system despite the challenges. publications, or is it the production of the last report for the ZDHS? It gives us these indicators of where we are. We scaled up the pediatric, ALD, and we started the implementation, most critically important, of the sustainability roadmap, which is the phase 2 of our plan. So I'll go on to talk about the priorities for this year, 2026, and the program needs to chime in. I will give them opportunities, those who are on the call. Yeah, so for HIV testing, it's to continue the rollout approach of the blood-based HIV self-testing kit in those provinces that haven't. Scale up male HIV testing in workplace through the revamping of the workplace champion modality. To scale up adolescents and young people HIV testing. This is some DSD for HIV testing in universities and colleges. This is critical. You can see that all these are meant to just restore our performance in terms of HIV testing. We need to strengthen index testing and social testing modalities, heighten the use of digital space for disseminating HIV testing and prevention, expand the use of self-testing, especially in the context of things like PrEP. Yeah. For PMTCT, we know that a third of the vertical transmission is for those mothers who are infected during or who seroconvert during breastfeeding. So we need to prevent those seroconversions. So prevention for mothers is key, very, very, very key. So priorities, next slide, Dr. Ziambo. We need to make sure that the testing, ANC1 testing, we go up. We've done well, but we can do better. Cohort and case tracking, integration of EPI and child health service, meaning that the testing and the, for children, the prophylaxis should be strongly linked with EPI services. Data quality, we have to do a deep dive in our data. We think this is a big challenge for our PMTCT services. We need to expand the use of PrEP for PMTCT this year, meaning we need to look at the data management, to ask for indicators to report how many pregnant mothers are on PrEP. Yeah, and we have to scale up injectable PrEP, especially lenacapavir for in PMTCT. Yeah, a roll out triple elimination operation plan and quality improvement for validation readiness and yeah. So the other thing that we need to do as a priority this year is the introduction of new prophylactic regimens. These are the new WHO guidelines. You see that there will be changes once we review the guidelines. WHO now recommends that you can use single prophylaxis for children who are exposed. And again, you can use ABC3TC DTG. DTG can be used for prophylaxis as well, then you can continue with single. So you will see that when we've changed our quantification for these commodities already, and once we are done with the guidelines, you see a change to have simplification of the PMTCT, including the use of single dose and DTG-based prophylaxis. You see here. Yeah, HIV prevention program, this is key. As you know, that this is where our objective of our program is, that goal of reducing. So everything is hinging around prevention. Yeah, next slide. Yeah. So the progress towards epidemic control, you can see that our target is 15,000, but we are around 30,000, you can see. So way off the track. And to reach epidemic control, we need to be at 6,000 new infections Yeah. So we have a lot of work to do to reach that target and to just showing that we are actually off track. With regards to our prevention agenda. Next slide, for example. Yeah. So in terms of our performance overall for HIV prevention, annual infections, you can see, like we've said, 2026, we expect to be around 30,000 of the estimations. PrEP initiations, 2025, you see that we dropped. 2024, we initiated annual PrEP to over 250,000 people. We reduced to 130,000 people. So that's a serious dip in performance. You can see in 2023, we have done much better. This is close to a 50% reduction in PrEP initiations. So we still have a lot of work. PrEP services, a slight reduction. Sexual and gender-based violence, we performed well. Next slide. When you look at VMMC, a steep reduction this year. So we need to do well. We need to do well. Next slide. Yeah. GBV, I've alluded to it. This is month by month. So one of the things that we need to do with that PrEP is to introduce the lenacapavir, and this is the roadmap. As you already know, that we launched on World AIDS Day, and right now we have 2 sites providing UTH and Chawama with lenacapavir. And we have PrEP methods that we are looking forward to having, including DVR and DPP as well among the oral. Yeah. So this is what we expect to have in terms of the lenacapavir doses. So huge doses coming, you can see from different partners, and we do have a roadmap. We have a task force to do that, looking at all other areas that needs to be done. Next slide. And this is just some of the pictures for the launch. You can see that we did on World AIDS Day. Yeah. So this is where we are in terms of LEN and CAB rollout. You can see that total facilities for total LEN initiations. The plan. This is the plan that we have is to have 159 facilities in 52 districts for LEN, and these are the facilities per province and also the targets that we have in terms of the plan. And we hope that not later than at the end of probably this month or next month, the commodities can come in and we start that expansion work in terms of PrEP. And our projection for PrEP, Dr. Ziambo, for just the previous slide, for 2026 is to have 400,000 initiations. You can see, so it's a lot of work that we need to do. And this is just you hear us talk about PrEP, because we think that is the hinge of our HIV prevention services. Next slide. And this is just the target for LEN by populations. You can see that we quantified for 2026. You can see all the way for initiations for which the population group. Next slide. So the focus areas is scale up of long-acting injectable. That's including 38 sites currently, which are providing carb, to 159, which will provide both carb and LAN. Introduce DVR and continue efforts to address age access to HIV testing, deal with stigma and discrimination, but we have to promote combination HIV prevention, including behavioral change campaigns. We've started the introduction of MAT, that's medication-assisted treatment. It's already started here at UTH, and this needs full operationalization. Next. Yeah. And we need to increase awareness for HIV prevention for AYP. We all know that the data from the DHS shows that knowledge for HIV among the adolescents and young people is actually reducing. So we need more social media, digital communication, more youth-friendly spaces and high-volume activities. And we need that integration between SRIH, risk reduction, and adolescents and young people, and HIV testing. We need to increase demand creation for PrEP and actualize the demedicalization for PrEP services in Zambia. And this means that PrEP should not be looked at as a hospital or activity, but a community activity. So we are developing a framework for PrEP provision at community level and with different delivery models. We hope that some of this PrEP should be given by community health workers. PrEP should be provided in private health facilities as well. PrEP should be provided even in private pharmacies as well, community pharmacies, those small places, a health post, so that it's actually that a truly community service. And we use the urban spoke model where each facility will have spokes in the community to provide this service. Next. We have to do with sexual and gender-based violence, increase sensitization, and strengthen care for survivors. But most importantly, we also have to improve the data management, including the use of PrEP in our EHR Pro. That's the small care. Next slide. So we'll have mentorship and on-site as activities, a lot of them, over data systems, community service delivery, pharmacovigilance, and the like. And we ask that all of us pay a lot of attention to this part of the program because it's a main program. We saw that there was that reduction of over 50% last year of PrEP services. Next slide. Initiations. Next slide. Pediatric and adolescent HIV program priorities. Dr. Ziambo, you can present.
You seem to be in the flow. Please continue.
Thank you. Yeah. So the pediatric and HIV service program goals is to achieve the 95-95 targets by 2030. We need to reduce morbidity and mortality related to HIV in children. We need to assist as well in the elimination of mother-to-child transmission, improve early infant diagnosis, and improve access to HIV prevention and treatment services for adolescents. Yeah. So key strategies towards achieving the 95-95 targets is case finding through multimodality testing, differentiated service delivery, optimization of ART for children and adolescents as per WHO guidelines, improve quality of care for children living with HIV, including use of viral testing using better modalities like a point-of-care testing, improving mental health services as well, and promoting cross-sectoral or multi-sectoral collaboration where other line ministries like Ministry of Education and Community Services, they come in. And the priorities will include to coordinate the implementation of the Global Alliance to End AIDS in Children Action Plan, which is already ongoing, and we know provinces are participating in this, improve access to the comprehensive HIV service for children and adolescents and young people by addressing access, age of access to both testing and prevention services, enhance HIV prevention and innovations for adolescents, enhance integration of HIV services with other related like EPI, SRH. We've talked about this, improve HIV case finding. We need to still go on with Know Your Child Status Plus and the like, and use other innovations, go to places where we've never been before. You saw that positivity rate for children still very, very low. And we need to deal with retention to care. We need to relook at EAC, Enhanced Adherence Counseling for Children. Is it working? The data shows we are seeing a lot of children on these chronic EACs. Can we do it better? What modalities we can put in place? So the major challenges have been the inadequate coordination, friendly spaces. We need to have more spaces, and I'm glad that there is some work going on here. We found some partners to support that, and consent barriers, age-appropriate services for minors who need them. This barrier needs to be broken, and some of these have led to low HIV case findings and poor retention as well, including viral load suppression. So planned activities for case findings, like we've said, we need to maximize on things like know your child status for both women and men. We need to deal with retention and improve viral load services. Dr. Zambo, do you want to amplify on any?
I think the biggest thing that we want to see in children really is an integrated way of identifying children in OPDs, in inpatient care, and in MCH, because that's where children most of the time go to. And these are the ones that have broken out through after the 24 months in EPI. The outcome is about 12%, 14% don't know their final outcome. So that cohort tends to go and they don't know the HIV status. So we would like to see those ones. Those are the ones that come in OPD. They're the ones that come for different services, the facilities. So we really need to optimize testing. That positivity that we saw in the performance wasn't so good. And so it requires a lot of concerted efforts in addressing that. And then, of course, we know that the children are dependent on their mothers. And so we need to make sure that we have retention mechanisms that support both the mother and the child to be able to attend the hospital, so that we need to scale up those evidence-based models that will keep the children and their caregivers in care. There's been some initiatives that have been tried out by different programs. We can try and work this out in such a way that they are cheaper to implement and affordable without a lot of external funding. And we need to develop a lot of SOPs that will support healthcare workers in the implementation of some of the strategies like the EAC tools, support the workers on how to test properly, things like that. Yeah, so generally that's what we're trying to look at in the pediatric program.
Thank you, Dr. Ziamba. And you can see that, we had a bit of challenge with the pediatric AOD. Again, all facilities are supposed to be providing that service. Next slide. Yeah. HIV treatment, support, and care priorities. Next slide. So you know that the goals of HIV treatment, care, and support is to have 98% linkage to care. These are programmatic goals. Retention should be at 98%. We are going up. 95% viral coverage. It was supposed to be 98% suppression rates. This is where we want to reach this year. We know almost everyone is at 95. 95% screening, prevention, and treatment for AHD. 95% screening for hypertension and diabetes. This is an integrated services. 95% of individuals should be on DSDs, including MMD, multi-month scripting dispensations. Yeah. So the priorities, the first one is the recovery of current on treatment. What we need to do here is improving our enhanced adherence counseling capacities and procedures. We need a lot of work. We've gotten a lot of feedback that things are not working as they are supposed to be. Backlogging of SmartCare Pro, we know, at least from our M&D sections, there are some provinces which have been praised, who've done a very good job with this backlogging, like Wapula, I think always comes up. And there are some provinces I'll be straightforward to mention, like he's here with me, Lusaka. You still have a lot of work to do this backlogging, but this is very important. As you've seen, we are still in the gray in terms of how many people are on treatment. So we hope to have the national and also subnational data quality assurance activities. Let's work on that data. There are a lot of mysteries. Other people believe, but let's work so that we know what is actually your TX car in your facility. Yeah. We hope that by the end of this first quarter, we stabilize. We all know, we are experienced, we know where we are supposed to be. Let's stabilize. And we need the promotion of patient-centered care, as usual, those good things that we are doing in the past. Viral load coverage and suppression rates, we need to recover as well. I know there are some provinces, Southern Province moved viral load coverage from about 90% to 68 or 60%. We need to go back. What do we need to do? Backlogging of viral load testing. These are activities that we need to spend time working on. We need to switch where we are able to POC testing platforms, especially for those priority populations. Innovations in viral load testing periods, we'll talk more about this, that maybe we can do things better for certain population, but community-based viral load testing, let's go in the community, get the bloods, using DBS cards, for viral load testing. Those are the things that we need to do. DSDs, we need to promote DSDs again. We need to revamp community-based DSD models. Where are the cards? Where are the cards? We need to go and do those things again. Integration of DSD with other programs. DSD cannot be standalone, let it embed with other program areas. We need to pilot 12-monthly DSD model. Let's see how this will work. There are some populations. Yeah, so we'll get some more instructions on this. But mostly we need to promote the full model mix or at facility level, including population-targeted DSDs. Again, we need to think of DSDs for other priority and the key populations, DSDs for school-going children, the scholar models, and all those things needs to come back to the fore. Optimization of HIV treatment regimens. WHO has released new guidelines, so we need to start thinking of how we need guidance of how to phase out AZT. Now you can recycle the NRT backbone. We need to optimize use of TAFED. We didn't perform well. We are still around 13% or 10%. Yeah. When we are supposed to be at 20 or 25% of individuals who are supposed to be on TAF, or living with HIV are supposed to be on TAFED. We introduce simplification therapies, and we need to prepare for the introduction of injectable ARVs for treatment as well. Advanced HIV disease programming, we need to scale up use of VCTech. Right now, we have a call that there are some VCTech cartridges which are about to expire. Imagine, while everyone is complaining about not having VCTech cartridges are about to expire, including fax fresh store reagents. I think some are expiring as early as March or May over there. So you hear some guidance of just how to make sure, and they are huge volumes. The volumes go maybe up to about 80,000, 90,000 tests. that we need to salvage. And it shows that the challenge has not really been the presence of these commodities. The commodities are there. It's how we've been conducting business. So we need to improve HIV data management as well, AHD data management, and we will revise the AHD guidelines, the new AHD guidelines from WHO. So we need to start the training and supervision visits so that we update the way we practice things. So there's quite a lot of information, and the draft guideline is available. Integration, we need to scale up this integration to facilities which haven't been doing them. Quality assurance services for NCD services in HIV spaces. We need to roll out the mental health package for primary health care. So I think December, Minister of Health approved. Now we have a signed mental health package for primary health care, which you can use, signed by the PS. This is something we've worked for maybe like 4 or 5 years now. We are happy that the work is done, the package is there to be used. And this is one of the achievements we had last year. Next slide. TB HIV program priorities, and this is just to, I don't know, Dr. Zambo, you can check if there's anyone, our colleagues from the TB program, but an end of term review for the NSP was done last year, and one of the things that the TB program wants to do is to come up with a new NSP. So major achievements in the 2022 to 2026 NSP was the good progress in case detection and treatment coverage, but you note that last year, case detection went down last year to probably one of the least in the last few years. So there were new things like adoption of new technologies, and we will have adoption even newer technologies as well as we move forward. Next slide, Dr. Ziambo.
So Dr. Mwanga is on the call.
Okay. Yeah. And so some of the challenges which we are faced is suboptimal access to WHO recommended diagnostics. Like I've said, there was a drop in TB notifications, and we need to recover. Yeah, you can see in 2023, there was that drop. Decline in HIV testing at TB service points. Again, higher death rates among previously treated drug-sensitive TB. This, we've seen it even among those with AHD, so like about 25% mortality rates and suboptimal DRTB surveillance. Next slide. So the priorities for 2026 is active case findings, TB case finding in special populations, TB contact investigation, introduction of near point of care technologies and scale up of XDR testing, scale up of shorter treatment regimen, the BPAM, especially for drug-resistant TB, and the shorter regimen for children, for drug-sensitive TB, cascade management for drug-resistant TB, and also childhood and adolescent TB, improved TB management. HIV TB collaborative activities, including testing and screening, needs to be enhanced, including TPT provision. If you look at our TPT performance, that dropped. I think it was over close to 50% as well, especially during that period where we had the stop work order. So we really need to recover, and continuity of services in emergency, flooding, and outbreak situations. Data is also one of the important areas. So lastly, next, we'll look at some programming innovations, things that we should look to so that we can start shielding our program against sustainability challenges. So we still need to think about sustainability as we move on this year. One of the things is let's have our HIV services government-led. We shouldn't have siloed programming. We've learned a big lesson, all of us, last year, and you've seen how the indicators have been impacted. So we need to work very hard here. We need to have support, one plan, one budget, and one M&D system. I know Assistant Director is going to say 1 or 2 words on this. We've written to some of the partners that we need to move towards this direction. The minimum package of care of HIV services, we need to implement it. We need to actively integrate HIV services into routine health services. And the word there is actively. So facilities which have got a TX score above 1,000, which are about 500 or so facilities, those will be standalone. Facilities with that TX score less than that, HIV services will need to be in OPD. And we'll be going through facilities. There will be tools. Look at that maturation, how facilities are moving, because it's a good thing that we move in that direction. So community HIV service model rollout, we need to come up with a sustainable way of providing community HIV services. Again, not siloed, not things like renting a house. But these should be cost-effective ways of doing these services. Integration of technical support and monitoring visit between GRZ, USG, GF, so that when we are doing these supportive visits, we want to do it together. So we've started with our USG colleagues to share our calendars with them. We have their calendar when they are going, and when we are going, we hope that we synchronize. You'll be seeing the teams working together. We want a monthly government-led by provincial and district program leads dashboard, performance dashboard meetings. Not partner-led. So all of us, we should know how we are performing. Biannual combined performance review meetings, we've been having these, and we have to continue. Active engagement of private sector in HIV programming, we need to offload. We are planning maybe 10% of the TX car needs to go to about the private sector. The mines, other places, they need to come in. And we need to that cross-line ministries in HIV service provision. We know that there is CDF with the community. You know, the districts have gone to the community ministry. You know, that decentralization agenda. These have to be real. It has to be realized. So there are some important activities to note in this year where some of you will be asked to come and participate. So most importantly, firstly, it's that revision of the ZCG, the guidelines. So we hope probably first or second week of February, when finances are available, we have to go and sit and start doing the work. So that over the course of the year, we start rolling out these new guidelines. The global fund writing, grant writing, we have to do the GCH writing. We know that the GRZ and USG support grant writing after there'll be some work, a corporate, country operation plan-like grant planning or writing that needs to be done. It will take some time, and we ask for your participation, those of you who will be called. We want to streamline HIV program digital health platform, including the scale-up of SmartCare Pro, and just look at how we can redo our digital health landscape. And there's a plan that is being written, with some support. So you see a lot of movement on the digital health and EMR space as well. And we have the sustainability roadmap phase 2 implementation to do. Everything that we wrote in the sustainability roadmap phase 1 needs to be done. That document. So in summary, This year, we need to recover and stay on track to achieve the targets. We know what our targets are by 2030. We need to think of sustainability. We need to embrace and scale up new technologies. So there'll be a lot of new things that will be introduced. We need to see how we can scale them. Thank you very much, Dr. Ziambo, for allowing me to share these slides.
Thank you very much, Dr. Sibile. That was quite a lot of discussions and things that you have brought up. Please take a sip of water.
Thank you, Dr. Ziambo.
Thank you so much, Network. I do appreciate your comments in the chat box and a lot of discussions in the chat box, a lot of suggestions, a lot of questions. And I'm enjoying all the discussions that people are putting on the chat box. Thank you very much. So before we invite people to come through, I am going to ask Professor Mlenga just to give his comments and on what has been said so far, and just highlight some key issues. Prof. Mlenga, are you able to unmute and just speak to one or two things that you would like to speak to? Professor Mlenga?
Thank you, Dr. Ziambo and Dr. Sivile, for highlighting the priorities for this year. Only additions or emphasis I can make are that this coming year we need to try and see how we can effectively sustain. And I'm sure working with the USG teams and also Global Fund, we need to look at the innovative ways of delivering services at a cheaper cost. But at the same time, we also need to look at how we can use the community health workers to take up some of the responsibilities or roles which were done, especially at community levels, by our various partners. One thing as well, which I think the teams need to know of, is that the way we deliver services won't be the same anymore. Even if we have any new funding coming from the USG, we don't expect that most of those activities which were previously being conducted will be able to be conducted in a similar way. So it's a time for us to refine how we provide services, but also a large emphasis on prevention. I think LEARN will be a very big piece of our agenda this year, but also at the same time, we don't need to force all that needs to go on prevention, to go on to LEARN. We need to provide choice, but as we provide that choice, we need to do it in a sustainable way. Another area that I think possibly we may start looking at this year using LEARN for treatment as well. So that is a 6-monthly injectable for treatment. Likely we may go into that area, especially after we have registration of lenacapavir for treatment, and that is for the treatment experienced individuals. And I think when we reach that time, it will be called for us to highlight how we move forward. There is also another area for HIV testing, I think, where we need to start thinking of how do we accurately and also timely diagnose those with acute HIV infection, especially the pregnant population, where we are having a high number of new HIV infections in pregnancy and also breastfeeding period. So those are areas which we also need to think of. Do we think that maybe the 4th generation may be a solution to that? And if we do so, how can we efficiently use it in the various subpopulations that we may consider? And I think majority of the issues are what Dr. Sivile has discussed with Dr. Kozia. I may be available to just answer any of the questions should they arise. Thank you so much.
Thank you so much, Professor Mlenga. We do appreciate those valuable and important comments you have made. So now we want to invite the network to actually, if you have some comments to make, and please raise your hand and unmute, and then we'll be able to call on your name to be able to speak. Already I can see Dr. Duncan Chanda. Please go ahead and unmute and make your comment. After that, we have Samson Standula to also make their comment. Please go ahead.
Thank you very much, Tim, for this presentation. And clearly, we have got a very challenging year going ahead. And I think we really have to be clear about how we are going to solve some of these problems. For instance, when we started the HIV response, maybe 20 years ago plus, there was a lot of involvement of the Ministry of Community Development, and then at one time the two ministries were together. We have seen how our community-based organization and CSOs have just basically disintegrated, and overnight we don't have that kind of service. I was going to suggest if I'm not sure if within the technical working group, there's a subcommittee which purely is looking at the community aspect. As you know, in our health care structure, some cadres like community health workers are never deployed at a certain level. Like I learned the hard way that we don't actually deploy counselors at a tertiary level. I just learned that because now we didn't have counselors from the program. So these are some of the things which even structurally the ministry have to rethink. Like we need the counselors to be deployed to secondary and tertiary level hospitals. But I think if we just leave it on its own, without having a group of people like a subgroup to just try and fill up that gap in the community aspect, and it has really shown that we needed that kind of service. Yeah, I'd like to hear the response from Professor Mlenga regarding that. I think a few other things I put in the comment box. Thanks a lot.
Thank you, Dr. Chanda. Samson?
Thank you so much for giving me the opportunity to ask this question. So my question pertains to going towards sustainability. I appreciate everything that has been raised. However, I noticed that the aspect of
Sorry, Samson, please unmute.
Sorry, I thought I was unmuted. So my question was, what are the plans that I didn't hear them nor get them concerning the sustainability plan going forward, concerning the human resource that has been and is under USG support. Why do I say that? I noticed that from the graphs that have been highlighted, there was a deepest dip in performance at the time that the stop work order came into effect, and subsequently had a knock-on effect throughout the year that led to the suboptimal performance in a lot of indicators. So I just wanted to hear if the ministry has any plans concerning the frontline workers and the people that are managing the courier, as well as the data that have been under USG support beyond this bridging gap. I know there has not been an official communication, but from what we've seen in the media, especially the USG, we know that there's been the postponement, or rather, I don't know, the cancellation of the fund towards Zambia, or the exclusion of Zambia from those countries that the USG is rolling out the new global health strategy. So that's my question. Thank you.
No, thank you so much. The question is noted. I think the Civilio, the prof will pick that up. One more comment from Laston.
So thanks very much for your presentation. I thank you, Prof. So we've talked about HIV, TB, on this platform today. We've also talked about the importance of holistic approach, of looking at numbers as people, and therefore the need for integration in the spirit of doing things not business as usual, but not as a song, but I think this time around it's changing the way we do business. Then one might start thinking and wondering. It all starts with strategic planning. Strategic planning, maybe for the aimed at goals and targets and milestones, may also be aimed at how are we going to operationalize so that we can achieve what we intend to achieve. I think there's need for critical thinking of integrating diseases that need to be integrated as we tackle these problems. So I'm thinking of HIV, TB, and therefore, how do we move kind of from now onwards together some of those STIs, etc., hepatitis, not as we've been moving. And therefore, let's not allow one group moving on their own, but as much as possible, create a system that looks at human beings when they come to the facilities, which we know, we have experiences from the ground, and we know what works. How do we get that on paper? And then how do we ensure that we start moving amidst dwindling resources? Because the story of resources is here to stay, not as a problem, but as an opportunity to think. I think I liken it to Zesco load shedding, not as a problem, but as an opportunity. Over to you, colleagues.
Thank you so much, Dr. Chitembo. So we have 3 questions. I think the first 2 questions, I might invite Prof to make a comment on that. The third question, we have the Assistant Director, Disease Control, Dr. Piri. He may also respond to that. In that order. Prof, are you able to pick that, the first 2 questions?
Thank you, Dr. Koza. The first question was on what? I remember the second is around HR.
It's on community health workers, involvement, Prof.
From Dr. Chanda.
From Dr. Chanda, yes.
Yeah, I think, Dr. Chanda, you raise an important point around our community health workforce. But beyond the community health workforce, it's the engagement of the community players. We know that the funding for the CSOs has gone down, and it's right, we need to have a place where we can discuss community involvement in health service delivery. And this should be better coordinated by the National AIDS Council. I suggest that we should be able to do that. Dr. Chanda, let's engage Dr. Msokotwane and NAC, and also the community, Ministry of Community Development as well, so that we can create a platform which is active and responding, especially to these current changes where the community has been really placed behind in most of the services that we are providing. But also, even through the same USG funding, once we go into the grant development process or the mini COP, where you say it, as done previously, if we can try and advocate under some investments, some community service delivery models, or how we can empower some communities, I think it's better for us who are on this other side, on the government side, to advocate for community services and the role of the community players in service delivery, as opposed to leaving that voice to the community, especially when resources are dwindling. Coming to the HR, yes, there will be information being given around the human resource workforce that has been affected by the USG funding landscape. their commitments, and I won't speak to the numbers, the commitments where GRZ will pick up a number of those healthcare workers. And also it includes some a substantive number as well for community health workers as well, those that were being supported through the USG. And those commitments are over time. So for this year, we know that there are certain numbers of healthcare workers we're supposed to take up the next year until 2030. And there is commitment from government within the available resources to be able to absorb those human, the health workforce. That's what I can say. But also just to say that the MOU, the discussions have not died, and the discussions are still ongoing. In fact, I think we are almost at the end of concluding those discussions, so that that MOU can be signed between the government of Zambia and also the US government, and that services will be provided, of course, in a new refined manner, but the funds will likely come from the USG, and we're about to conclude those discussions at that level. Thank you so much.
Dr. Ziambo, we can
We as the Ministry of Health have failed to.
Dr. Zambo, we couldn't hear you.
Oh, apologies. Thank you. Thank you so much. I was muted. I was saying thank you so much, Prof, for the very, very insightful responses. So now I was handing over to Dr. Piri to pick it up on the third question by Dr. Chitembo on integration.
Thank you very much, Kozia, and thanks, Dr. Chitembo, for the submission. I see your submission not necessarily as a question. I see it as a call basically to action, and I would want to report to you that this is a discussion that is very much alive in the ministry, and the challenge that I think we've been having in the past is that we've not been having comprehensive plans as a sector on which partners need to buy into. Now that we've got clarity on what our priorities are now and how we'd want to deliver on those priorities, the next step is to develop a comprehensive plan that is government owned, and is into that particular plan to which partners must buy into. The challenge is that if you don't have a plan, partners will come and create a plan for you, and this is one thing that we want to put behind. And so our management has clearly challenged us to actualize the one plan, one budget, and one M&E principle this particular year. And the only way we're going to do that is that we need to have comprehensive plans. And you'll be seeing letters soon flying from our principals to your institutions and the different stakeholders, calling on all of us to get to a place where we should develop this plan. And this is a plan to which the Global Fund will buy into. This is a plan to which the USG, once we sign there, we need to go. And that's a comfortable looking at integration, because
I think we have lost Dr. Piri. Dr. Piri, I don't know if you are done with your comment. Okay.
I'm done with my comments. You lost me. You couldn't hear my statements?
The last statement, just the last piece.
Oh, so I was saying that in integration lies efficiencies. And yes, what has to be integrated must be integrated. Thank you.
Thank you so much, Dr. Piri. So thank you very much. I hope those are some of the responses helping us to understand the direction for the government. I've got two more hands and very few minutes remaining within our time. I'll invite Munkombwe. Your hand has been persistent for a while. and then we'll have Annie Dop from DAP. In that order, please make a comment.
Sure. Thank you so much, Dr. Zambo and Dr. Sivile. Dr. Zambo, just confirm audibility. Am I audible?
Yes, we can hear you.
Not too. Okay, let me just be very, very quick. Okay, so yeah, I'm Arthur Mumkombwe, and currently I'm not aligned. I'm non-aligned. So maybe the first question, Dr. Sivile, is lenacapavir, availability of lenacapavir. We've just seen it in hospitals, first level, probably referral centers.
Sorry, Mkombe, go ahead. Sorry about that.
Sorry for that, because I'm trying to be quick. So maybe that's the first one. The rollout plan for lenacapavir injectable, because we want to see it actually going down. And maybe this one as well will go to my professor, Professor Mlenga. I don't know if he's still on the call. Are we considering foregoing certain positions on Global Fund, let's say on USG, on CDC, for example, clinical, based positions, to prioritize community-based positions? For example, in the Wales provinces, West, East, Lusaka, Southern, I think we've seen the number of our CBVs being laid off. This is a reason, I think, Dr. Sivile, why even the 200,000 that we lost at the end of last year to retention is basically because our CBVs, our foot soldiers, the key and the engine to retention, to viral load, even to linkage, are being laid off. So maybe I just wanted to get Professor Mlenga's opinion on this. The little funding that we have, for example, COAG, CDC, can we prioritize retaining quite a number of CBVs as well to this? And then maybe the last one, I had 5, but maybe I'll just cut it because of time. Looking at the sustainability plan for USG provinces, USG funded provinces, Mchinga, Luapula, Northern, you can go on and on. But we are not seeing the rollout of CDC COAG as it is. Maybe the question as well would be, once the little fundings are being given to these USG funded partners, are we seeing intensifying the sustainability plan by going the Wales provinces way, like the way Dr. Sivile, I think, was trying to emphasize? I don't know whether those 3 questions are very clear. Maybe the other 2 are just comments. The TXCAR of facilities is below 500. Putting the services into OPD is a very, it has a lot of that in place and infrastructure. That may actually not.
Sorry, Mkombo, you seem to be breaking, and we can't hear what you're saying. On your comments, sorry about that.
When
Sorry, we lost internet here, and apologies for that. Thank you. Annie Dop, would you like to make a quick comment before we respond to those questions from Nkombwe?
Yes, thank you very much, Dr. Sivile, Dr. Mulenga, and you for this presentation and these very clear results from 2025 and the comments on what could have happened. We can see, yes, we are lacking funding all over and lacking staff all over. But this is a strong recommendation that we pick up the community component. We need to involve community. We need to have them on board to promote these health services. We need community programs and in very, very closely collaboration with MOH or hand in hand, so to say. And in integrated services, so the comment goes to the priority of having some community programs back in the funding that comes into the country as a very strong component to achieve the results that we need to see this year. So we are supporting Prof. Mulenga, important component. Thank you. Over.
That comment is very welcome, and I think it's appreciated. I think in some of the slides you could hear emphasis that Dr. Sevilla made about restoring a lot of community activities that we've since were put on hold, and I think that's one of government's intention to see that implemented. Dr. Sevilla, any responses to the earlier questions?
Yes, there was a question on LEARN rollout. Yeah, so I think if you followed the slides, that is there. It's clear we have a clear rollout plan targeting 159 facilities in about 52 districts in all the 10 provinces. So that is done, and we've started with 2 facilities, but at the end of this month, we'll have that for, and I did share even the amount of land that will come. Yeah, so we expect some of it to start coming over close to, the month end of January. After that, the scale-up plan will start. Gradually, we'll be open sites, but by the end of the year, we know that we're supposed to have 159 sites active in 52 districts in all the 10 provinces. Thank you. Yeah, I think there was I saw something, is it on the chat, talking about the facilities with a TX below 500? Yes, so we've done some arithmetics. If you can follow just to show, Dr. Zamba, I don't know if we are able to move this slide. Yeah, that we are seeing. Yeah, you'll find that almost all of our TX car, about 70 to 80% of our TX car is resident within about 593 facilities which have a TX car above 500. If you look at this arithmetics, that 77% of the TX car is in that 593 facilities which have a TX car above 500. And so all these facilities, which are about 593, these facilities, we know them, and you'll be interested to know that most of these are within small districts like Lusaka. Those 29 which have got high, I think there should be just 1 or 2 outside Lusaka. So these would like them to be standalone facilities. Then the rest which have got TXCAR 1, 9, and so on, I'm sure you wouldn't want to have a separate ART clinic if your TXCAR is 80, is 20, and so on. Let that be part of OPD. So that should be emphasized so that resources are spared for other things. I think that's the explanation. Thank you.
Then the comments from Comwe?
I think the number of those comments were already alluded to by Professor Mulenga. Obviously, when the grant-making process starts, obviously, as government, we are not a USG to give you probably a full story. But everyone must understand that this bridge plan is not exhaustive. It's like it's a bridge plan. That's the language. And the proper plan will be made once the MOU is signed. So we'll sit down, make the plans, where we want coags to be put, those questions that have come, which human resource, and there's a proper scale-up plan even for human resource, which is part of the MOU. And like Professor said, those efforts haven't died. If you've seen that in the social media or wherever, it's not true that they've been withdrawn. That's far from the truth. So I think the short and long to that is we will make a proper plan, and we are very grateful that you've given those consider, or is it advice? But right now, probably because there is a space for community health workers, even in that plan. So the intention will not be to freeze certain clinical health workers' position so that you open community health workers. There's a proper plan already in place. We have the numbers of what we need. So the need will be left as it is and see how we can fill up that need, make sure that the people are there. So there are some plans. I think once we start the mini COP, I think it will be clear for everybody. Thank you.
Thank you very much. I think we've run out of time and we've gone into about 10 minutes beyond our prescribed time. But we want to thank you all for your patience and being here on the call and having a very fruitful discussion. We really appreciate your availability. Before we wrap up, are there any key issues, Dr. Sivile, you want to mention?
Yeah, just to remind everyone that probably this session is not meant to be exhaustive. We'll have exhaustive sessions for each program area. And this was just to give that overview of where we are and pick up the most important things that we expect this program. But as you've seen, there's a lot of work cut out for us. And we treasure your participation and your commitment. And we are very, very grateful for the work that you continue to do on behalf of the Ministry of Health and the people of Zambia. So thank you very much. We've seen that the attendance was very good, close to 600 people. Facilities attended? Yeah, so thank you very much for your time and looking forward to work together as usual.
Thank you so much, Dr. Sivile. Thank you, Dr. Piri, Professor Mlenga, thank you so much. And this marks the beginning of our echo sessions. We did pick out a survey and we did get some of your key topics that you wanted to see this year. And all those have been put together into a curriculum. So starting next week, we'll begin to address them and unpack some of these things that we've talked today about and for everybody. And so that we'll go into details on how we'll be able to implement the program, how do we improve, how do we recover from the challenges and experiences of last year. So thank you very much. We look forward to seeing you again next week as we continue with our interaction on this platform. Have a good day. Thank you.
Thank you.